Welcome to season 14 of the Regimen. Joining us today is Kaitlyn Staskywicz for a fascinating discussion on her Indian Health Service, or IHS, junior COSTEP internship experience and the innovative roles of pharmacists in this branch of the public health service. Hello, pharmacists and friends. Today is Wednesday, June 19th, 2024. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues and solutions. Listen in to find out how we all can improve population health, health equity, and patient care through advocacy and education. My name is Liz Arnold. I'm a sixth and final year Doctor of Pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg and the Rhode Island Department of Health.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the academic collaborations officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
We are thrilled to welcome Kaitlyn Staskywicz, URI PharmD class of 2026. Thank you so much for joining us. Can you tell us a little bit about yourself?
Yes, thank you for that introduction, Liz. Like she said, my name is Kaitlyn Staskywicz. I'm in my third year of pharmacy school at the University of Rhode Island, so it's going into P3 year. My opinion expressed on this podcast does not represent the views of the United States government, the United States Public Health Service, or the Commission Corps. I'm from Massachusetts originally, but today I'm reporting to you from the very rural town of Pine Ridge, South Dakota, part of the Pine Ridge Reservation, where residents have the lowest life expectancy of anywhere in the country. And let me just put that into perspective to you. The average life expectancy for males and females, respectively, is 47 and 52. I'm here with the Commission Corps as part of the Junior COSTEP Externship Program, also known as the Junior Commissioned Officer Student Training and Extern Program. I didn't choose to go to Pine Ridge. The Commission Corps sort of matched me here. And you know what? Being here for a couple of weeks now, I know why. The health disparities of this community is just nothing like I've ever seen before. Between the lack of transportation, the limited government funds, never mind limited employees, I was placed in a location where I'm destined to grow as a human being and a pharmacist for the future.
So historically, we've seen devastating epidemics of, for example, smallpox, influenza, and sexually transmitted infections, or STIs, and they disproportionately affect Native Americans. We're still seeing it today with COVID-19. So researchers have found that deaths from COVID-19 infection in the Native American population were almost 4 times higher than in the white population. Other disparities that were identified through research were access to healthcare, overcrowding, and then lack of safe drinking or running water, among many, many others.
Yeah, there's definitely a population that, as Kaitlyn and Liz have said, needs our care and needs more people to help close these gaps in healthcare. One could think of this as any marginalized group, which is often immigrants throughout history, whether it's those from Europe in the 19th century or the 20th century, or even currently immigrants from Mexico, Central and South America. For them, they lack access to healthcare. They're less vaccinated, may not have antibiotics, and again, may live in overcrowded areas because of the housing crisis. But we've figured out ways to mitigate those to varying degrees. But for the population that's always been here in North America, the indigenous population, these solutions still seem out of reach. So why is that?
To paint a picture of why we're seeing disparities amongst this population, let me start off by saying the area that I'm in right now, it's very rural and it's very poor. Multiple families can be living in one trailer home. The majority of the population, they're unemployed. There's violence. There's overflux of dogs running around on the reservation. And, quite often they bite people. And again, that's another opportunity of an infection. There's substance use disorders, particularly alcohol and methamphetamine. This is actually a dry reservation, so they prohibited the sale of alcohol on the reservation to help combat that substance use disorder. But we still see a lot here. And then there's the battle of mental health. The suicide rates are shockingly high still, but they're decreasing slightly each year. Besides little mini market in town, the nearest grocery store, it's an hour away. And I wouldn't doubt today that that's a reason why we see a lot of type 2 diabetes. There's no access to fresh foods. And the food that is here, it's, double the price because they have to ship it in. And then, of course, there's no transportation on the reservation. at least in Pine Ridge, I can't speak for the other parts of the reservation, but there's no public transportation. And, access to the internet is not always reliable. A lot of people don't have laptops, they don't have computers, they don't have phones. So these are just some of the surface reasons why we see this population suffering.
That's quite a list of disparities there, and they all seem to intersect. Not just, again, we see geography, you talk about rural populations, you talk about eating. These are all what we like to call social determinants or social drivers of health. I prefer calling them social drivers because they can either drive people to health or drive people away from health. And to play on that term, again, the transportation's the thing. If you have transportation, is the grocery store where you're going to go? And if everything's priced out of reach, which is maybe a problem writ large through inflation and other things, you're not going to choose the healthy food that's more expensive. You're going to choose the less expensive food, which maybe by definition is that. And if you don't have access to information, with the internet lacking, I think that there's efforts to increase broadband access in rural areas, but I don't really know what's happening in tribal areas. Just going back to diabetes, I think it's important for our audience to know that it's associated, people who get diagnosed with diabetes are associated with more severe heart disease. So then you need all kinds of medications to prevent severe consequences of that, like stroke and heart attack. Lots of kidney disease. Kaitlyn's going to talk about working in the dialysis unit. People who need dialysis are those whose kidneys have failed, and that's often complicated from both heart disease and diabetes. And then diabetes makes your immune system not work as well and makes your circulation not work as well. So now you have this bad combination of poor conditions, maybe poorly controlled diabetes and heart disease, vascular disease, so that now you have infections. And we'll talk about the incidence of skin infections. You talked about getting bitten by dogs and things like that, bloodstream infections. And there's even vaccine preventable diseases like hepatitis B, which are often seen in higher prevalence. And so there's lots of opportunities for healthcare providers to take part.
So, Kaitlyn, you mentioned that you're an extern with the U.S. Public Health Service COSTEP program at Pine Ridge in South Dakota as a rising P3 pharmacy student. So can you tell us about what the program is and how it's different from the advanced pharmacy practice experiences or APPEs that I'm currently doing right now in my final year of the program?
Yeah, so I would say the best way to describe the program is kind of like a pre-APPE rotation with some similar and very different experiences that one would, usually have during their introductory or advanced pharmacy clinical rotations. I applied to this program this summer going into my P2 year, and then I was selected at the end of October during that same year. I then spent the time from November to May kind of talking about the logistics, doing lots of paperwork, extensive background checks, but in the end, it was all worth it. And then during my time in the COSTEP program, I'm just really mainly able to apply my pharmacy education so far. And I would say like a really low stakes setting with the support of my preceptor and the pharmacist around me. They push me to beyond what I think I'm capable of doing. And, I know once I start my APPE rotations, I'm going to have an easier transition with the real life application of pharmacy to my patients, and I'll be more confident in my skills.
Can I just ask one quick follow-up? Are there other students there, or are you the only one at this location?
So I'm the only pharmacy student. There is a COSTEP in biomed right now. He is doing chemical engineering in Nebraska, but there's not a lot of COSTEPs in the country. I think they max it out at like 35. So it would be rare to see another pharmacy student. But again, in Pine Ridge, the area is so kind of needing. It's not shocking to see another COSTEP here.
That sounds like such a great opportunity. So what have you been doing there?
So I've been working on a lot of projects. One of the projects I was dealing with the hazardous drugs. I moved medications that were stored in the hazardous room that were non-hazardous out. That included a lot of the HIV medications that they just assumed were hazardous. But I looked it up and everything's fine. So brought them back out to the shelf with other non-hazardous medications. I've completed risk assessments for some of the medications that needed to be updated. And I did a lot of monographs for the P&T committee when there was requests to add medications to the formulary. And then along with the projects I'm assigned, I get to spend time in the emergency room. I've been to the jail and the mobile health unit. I've handed out Narcan at the powwow. And I've had opportunities to collaborate with, members of the healthcare team.
So you mentioned adding meds to the formulary, we've had a few podcasts on this, on, the obesity epidemic, and you mentioned that as one of the factors that this population disproportionately has. So is IHS or is your location getting this class of drugs that used to treat obesity and has also great outcomes in diabetes and in heart disease? Are those on the formulary there? Are they being used?
Yeah, they're being used. We do a lot of Ozempic in the pharmacy, in the clinics. I wouldn't say everyone's getting them, but we do a lot. And there's no shortage here. It looks stocked every time I see it. So yeah.
So it's kind of good. I mean, here's this, what I think of as a transformative class of medications, accessible and not in short supply for this population. There's plenty of other things to solve, but that sounds like progress. So,
Yeah.
speaking of those medications, what kinds of, you mentioned some things that you've done in the pharmacy. Tell us about some of your patient-facing experiences.
Yeah, so I get to counsel the patients on their discharge medications. We have a very small inpatient unit, but every day we still seeing patients in and out, and I get to counsel them on their antibiotics mainly using that antibiotic stewardship. We switch them from IV to oral for discharge. And you have to think that going back to the Ozempic, it's hard for patients to kind of come in and get the prescription sometimes. So they might not be able to come every month and get that Ozempic. And then you see patients fall off their kind of regimen and then they have to start all over. So that's a reason why we're not seeing like a whole bunch of it go out, but we do see a lot still for the people who can get there. But speaking of Ozempic, again, I was able to counsel someone on their new start of Ozempic. And that was pretty meaningful. That was my first kind of counseling experience with Ozempic.
So maybe I think you talked about patients having difficulty getting their medications. You had mentioned transportation difficulties. Maybe we could take a step back. Like, how big is the reservation? Like, how far do people have to travel to get to where you are? And then the other thing is, I think our audience is curious about, do they have to pay for the medications, or is this like a publicly financed program?
Yeah, so the reservation itself is pretty big. South Dakota itself, you wouldn't believe, but it takes, 8 hours to get across the state. I'm not sure exactly how big Pine Ridge Reservation is. I'm assuming it's kind of like the size of Rhode Island, if I had to put it into perspective. But the patient's prescriptions, they don't have any copays. The IHS covers that part of their copay that they may have. I know patients also have the opportunity to get, commercial insurance in case they were to go off the reservation and not to an IHS clinic. And if they wanted to go to an urgent care in like Rapid City, which from here, Rapid City is over an hour and a half away. And that's pretty much your nearest big city area, if you will.
Rapid City is not Boston, I hear, I would say, for reference. Liz and I were just talking about driving all the way from Rehoboth, Massachusetts to Westerly. And I think 8 hours across the state is probably a little different than driving across Rhode Island. So
yeah,
comparison.
Yeah.
So you had mentioned to us before that you had spent some time working in the emergency department there. Can you tell us a little bit about that?
Yeah, so I spent some time in the ED shadowing some of the pharmacists that sit there. One thing to note is there's usually a lot of med flights going out. Pine Ridge isn't really equipped to deal with some of the more severe traumas that we see. So the emergency room's usually like stabilizing the patient, stopping any bleeding, getting their vitals stabilized, and then they're getting med flighted out to Rapid City or whatever the nearest hospital they need. Here, the pharmacists also spend a lot of time making sure the correct antibiotics initiated for the patient at the correct dose and the correct duration of time. Antibiotic stewardship's so important here when it comes to urinary tract infections, surprisingly. From the antibiogram reports I was looking at, I've seen very high resistance when it comes to UTIs here. And it's important for the pharmacist to recommend an antibiotic that's actually going to cover the bacteria that they're looking at. And then that was one of the formulary requests that I did for the P&T committee. I requested to add fosfomycin to the formulary to kind of help combat that high resistant rate. And then not only are we seeing, problems with the UTIs, there's also a syphilis crisis here. A CDC report that came out in January of this year showed that South Dakota had the highest rate of primary and secondary syphilis out of all 50 states in America. Never mind that the rate reported cases being doubled that of the second highest state, which was New Mexico.
Yeah, it shows all our podcasts are linked in some way, right? And so Liz and I will have a podcast on actually non-antibiotic treatments for UTIs coming out. So, there's guidance there. And actually, there's a publication that came out yesterday in a Journal of the American Medical Association about using electronic health records to help people select the correct antibiotic for UTIs or pneumonia. Which brings back my next question so is there an electronic health record? I mean, I assume it's like a modern clinic and you've got EHRs and things, or what's that like?
Yeah. We use a government kind of system. You can see their medical history, all their medications from the past. There's access to like the notes from all the ER visits, doctor visits, all the labs, which is very important. A lot of the pharmacists are looking at the labs and making sure XYZ medication is okay to take according to the labs. So yeah, we use those a lot.
Yeah, so it's probably very similar to the Veterans Administration or the VA, where lots of pharmacists have a great scope of practice, just like IHS, and are able to perhaps even prescribe things or, write notes and really work as a team there. So speaking of team-based efforts, you had mentioned that you had done some counseling to patients on their discharge medications at an off-site clinic. What were some of the other tasks and things that you did there?
I did some basic pharmacy technician type work, including like ward inspections, filling of medications, and handling the pickup window. And which, speaking of the pickup window, almost every item in the pharmacy needs prescription, and that includes the over-the-counter medications such as Tylenol, ibuprofen, sunscreen, and that's mainly due to policy at Primary Service Unit. There are some other IHS facilities where this is not the case, and patients can, come to the window and ask for Tylenol, and they'd more than happy give it to them. But looking at a financial point of view, again, like I said, the Indian Health Service covers the copayment for a patient for all their prescriptions. And that includes Ozempic, Humira, whatever prescription they need. And when they left Tylenol, ibuprofen, et cetera, up for grabs, they were seeing people, come in with a laundry list of items, but not seeing those items going to the patient. They're, being sold on the street, which is, they don't want that. And, now you might be thinking, what if Miss Smith is coming in for her grandma who can't make it to the pharmacy and pick up her medications? Well, in Pioneers, there's also CHRs, which are called community health representatives, and they're kind of the go-to people, and they pick up medications for those who can't make it to the pharmacy, and they get patients doctor's appointments or, whatever they might need. And again, there is an exception to the prescription process. We do give out lice shampoo, Plan B, condoms, diabetes testing supplies, including lancets, testing strips, pen tips, etc. And we also give out Narcan, all without prescriptions.
I actually do have a question about was it the CHRs? Are they signed to people, or do you kind of have to request them in advance? How does that work? If you know, it's okay.
I'm honest, I don't know.
That's so interesting.
I have a follow-up to the follow-up. So do you have controlled substances there? Like, can people, again, like in many states, people have to show an ID and to either get to pick up meds that are controlled substances. Like, how does that work with the CHRs or just controlled substances in general?
Yeah, so anytime, any prescription, the patients are supposed to show an ID. Sometimes we let it slide if it's not a controlled substance. If it's a controlled substance, we need to see an ID. Or on the screen, it'll pop up being like, these people is a CHR. It's kind of like on their profile. And they are tracking gabapentin as a controlled substance there. That's another kind of difference that I saw.
Yeah, that's very similar to Massachusetts does the same thing. So
yeah, and what you said about the Narcan without a prescription earlier, we love to see Narcan in everyone's hands. So is that OTC?
Yes, Narcan is OTC now, which is, still a shock to some people. I was able to hand out Narcan amongst other things such as Plan B and condoms at the powwow that was happening on the reservation with one of the pharmacists in the Commission Corps. And for anyone who's not familiar with powwows, they're kind of an opportunity to celebrate and honor the Native American culture and heritage by dancing, singing, socializing, eating.
that's great. I mean, I think that, we all know my friend and colleague, Dr. Jacobson, Anita Jacobson, in our project that go to all kinds of cultural events, hand out Narcan, fentanyl test strips, and all kinds of harm reduction supplies. You had mentioned earlier Narcan reverses opioid overdose, but you said the main problems are alcohol, even though it's a dry reservation, but they go across the border to Nebraska to a town that has only a handful of people, but like many, many liquor stores. So that's a thing. And methamphetamine, which Narcan also doesn't work at, but we'd see fentanyl, which is an opioid contaminating these things. So I'm sure that that's something. So I guess I was just reading about fentanyl test strips this morning, which are now available at a large chain pharmacy locally. I just found out yesterday. And is that something that you're about? I know there are limitations on those kinds of things.
I haven't seen fentanyl test strips here. Again, I haven't also heard of the overdoses with methamphetamine,
Hmm.
um, maybe being laced with fentanyl, but I also haven't seen a lot of it with my own two eyes, is what I'm saying.
I've only been there 2 weeks, so I think that's fine.
Yeah.
So are there any stories or like memorable moments in particular that stuck out to you?
Yeah, so I was able to visit the dialysis clinic and I was able to shadow one of their wonderful nephrologists for the day. And while I was here, I was able to work with the medical team and I was able to help one of their dialysis patients simplify their medications. And I mean, there's medications in there from 2020 and you can't even read the label and XYZ is not on the medication list anymore. So it was kind of shocking to see how it kind of got like that. But I was able to work with her and in the provider and set up a public health nursing consult to work with the patient and get her team to fill her medication box each week to kind of simplify that pill burden because she's taking like 20 pills a day and I can see how that gets a little bit confusing. This patient in particular was kind of picking and choosing which medications they wanted to take each day. And, I was able to counsel her on the importance of taking everything as prescribed by her doctor. We can't pick and choose which medications we want to take. The dialysis patients, they have quite the extensive medication regimen, and oftentimes they're confused on what to take and when. So it was definitely rewarding to relieve some of that pill burden and stress that the patient had by setting up this kind of operation.
Yeah, that's fantastic, Caitlin. That's something that pharmacists do all the time. It's essential. And if you can't read the label or things, I'm sure that's also a bigger problem there too, potentially in terms of just overall health literacy, right? And what the education's like there. But it really means everything to sit down with the patient, help them navigate all those things. And I'm sure they appreciate you take the time to connect with them and make things easier. There's a lot of distrust between Native Americans and other marginalized populations in the healthcare system. So anything that builds trust builds adherence, which decreases all the, negative potential outcomes. Was there anything else that you'd like to share?
Yeah, I was able to also visit the jail that's in Pine Ridge on the mobile unit that they have. And, the best way to describe the mobile unit, it's kind of like an RV doctor's office on wheels. And during this time, I was able to observe the PA while he saw the incarcerated individuals.
Yeah, that's nice to see how other disciplines work there, like working with the PA. And I'm sure you had the chance while being inpatient or even off site in that clinic to work with other disciplines as well and see how everyone collaborates together.
Yeah, the incarcerated population is always fascinating to me in all kinds of ways, especially studying addiction and overdose and infections and promoting decriminalization and things that on top of all these health disparities, one other factor that adds to disparities actually being incarcerated as a social driver of poor health and quality of life, and it affects the whole community. We've had several examples of, you've got these community health representatives or you have family picking up things like that. Like, what was your thoughts in seeing these incarcerated folks? Are they, treated the same, or, you mentioned there's higher rates of crime and things. What is healthcare or anything different for these imprisoned people?
Well, I first want to say that the PA did a wonderful job just treating them as, human beings. He didn't look at them as they were in jail or anything else like that. From a healthcare perspective, there wasn't a whole lot that we could do. The PA was able to do refills and get them any other medications they may need for any few problems. But beyond medication, if they needed an eye exam or they needed to go see the orthopedic for their knees, they had to wait until they're out of jail. Which sometimes they can wait, and other times it's like we feel really bad because there's quite literally nothing else that we could do. So that's what we're seeing. But the PA, he was able to set up some referrals for, when they were able to get out of jail. And he was encouraging, good behavior and just really pushing to like stay out of jail to be the best healthy individual that they can be.
It sounds like you've gotten the chance to experience so many different areas of healthcare, which is awesome. Sounds like a really, really great experience so far. So what made you decide to apply in the first place?
The first reason I wanted to apply, I wanted to help people that are in need. I've heard of the health disparities and the social determinants or drivers of health that affect the Native American populations, but my own two eyes, I've never seen it myself, until now. I've never seen rural pharmacy, never mind government pharmacy. We don't talk about that a lot on the East Coast. We have some VA systems, maybe some Medicare and Medicaid areas, but it's really not a focus in the East Coast. But I also wanted to, be able to come out here and share what my experience is like in hopes other students realize what a great career this could be for pharmacists and what a different opportunity it really is.
Yeah, my only memory is a student many, many years ago went to do a residency in Nebraska and he was a surfer. And I said, there's no ocean there. So I hope it's a year, you're busy, but be careful. But I'm a person who grew up in the Midwest and trained there and grew up in a rural area. And so it really is. It's a very, very different place. You talk about driving 8 hours, and I think about driving 4 hours to a concert when I was young. And I would go to a concert and then drive home and 3 hours later go to class, the fun things that we did in the in North Dakota. But it's interesting that when we were putting this together, I thought of this conversation I did have 25 years ago. I was in northern Minnesota and I was at a small hospital, a critical access hospital, did the same things where we med-flighted people out, we stabilized people in our ED, had like 20, 30 patients inpatient at the time. But there was a student that we connected with who was at the IHS, and she said, this is public health service is where it's at. It's like government service. You work 20 years, you get a full pension, full health care benefits. We give out a public health service award every year, like all pharmacy schools. And so I get to usually be part of that and talk to the Coast Guard pharmacists because we have lots of Coast Guard folks, or our Department of Justice folks, federal prison system. It's a really not well-known service, but they do such great things and really provide service there. I've worked with a group in Montana trying to do medications for opioid use disorder in a place where there's just literally no health care, and how hard it is with the transportation problems. I really like that you're experiencing this as a Massachusetts person going there, and I sort of went the other way. I think that we should really advertise those kinds of things. So can people apply now, Kaitlyn? What's the deadline?
That I don't know.
That's okay.
I was going to apply for the next program myself, but he said it's not open. The government found me yesterday and called me, and they were like, it's not open until August. But then he said something about the program that I'm doing now, and I don't know if he said it wasn't going to happen next year, or I don't know, something about budget, and
sure,
they're making it more competitive because there's going to be less spots, I think.
All you got to be is a URI student, though, right? If you go to the top 25 school in the country here at University of Rhode Island, then you've got a good chance. You're there.
Exactly.
Kaitlyn, any final thoughts you want to share?
Yeah, I mean, it's all about stepping out of your comfort zone when it comes to pharmacy. I never thought that this is how I would be spending my summer going into P3 year, but I've grown so much as a person and a student, and I cannot say I regret anything. If I were to give advice to any of the other pharmacy students, I would say don't be afraid to take risks and step outside your own comfort zone. There's so many areas of pharmacy that you might not even consider if you don't let yourself be open to the possibilities.
Couldn't have said it better. Well, that concludes our episode on the IHS Junior COSTEP program. Kaitlyn, thank you so much for joining us. It was great hearing about your experiences.
Yes, absolute thanks. That was great. Be sure to find out more about the Regimen Public Health Podcast here at PharmD Pub Health. That's pharm as in pharmacist at PHARMD as in Dr. Pub Health on Instagram. Connect with us on LinkedIn. Turn on those post notifications so you never miss an episode, and smash that subscribe button now, if you haven't already, on Spotify, Apple Podcasts, YouTube, or wherever you listen to podcasts. Thanks so much.